Coronavirus has dramatically altered and is still altering the way people live their lives. Certainly not the first global pandemic in living memory, but the nature and impact of this virus on human relations, international trade, and politics is already being spoken of as something that can never be equaled. There are already projections that a failure to develop a vaccine in good time could spell doom for between 60 million and 100 million people. This type of information, in turn, continues to feed into people's fears in the process, raising multiple questions and myths around the coronavirus disease, or COVID-19. Joining us now to talk about some of these frequently asked questions about COVID-19 is Dr. Titilola Obilade, an associate professor of public health at Nile University, Abuja. Good morning, Dr. Obilade, and welcome to the morning show.
Good morning. Thanks for joining us.
Good morning. Thank you so much for joining us.
Yes.
Thank you for having me.
Yes, thank you for joining us. Well, quickly, let's start with the talk about chloroquine as a cure or a solution to COVID-19. Only a few days ago, President Donald Trump of the United States was recommending hydroxychloroquine or chloroquine phosphate. Previously, he had recommended azithromycin and remdesivir. And also here in Nigeria, we've had some political figures coming out of isolation center and talking about chloroquine and other drugs. Now, some people have said this is not right because no cure has been found yet. But chloroquine keeps coming up, and Professor Adeyeye of NAFDAC says chloroquine is being tested in some clinical trials in Nigeria. Why the focus on chloroquine, and where is the state of research at the moment? And is it right for political leaders to be talking about a particular drug?
Okay, once again, thanks for having me. About chloroquine. Chloroquine has been used in Nigeria and most of Africa, where we have malaria has been endemic for several years. If you are 20 years old and above, you must have used chloroquine for malaria. Now, let's look at it this way. When you used chloroquine for malaria in those times, what were the side effects? Was it so much so that it killed the person? Okay? Now, chloroquine, the properties of chloroquine, it has antiviral properties as a certain concentration on coronaviruses. Now, the SARS-2, that's the coronavirus, the COVID-19, it is a coronavirus. That means that chloroquine has an effect on the replication process of the virus. Okay, and it has side effects, yes. But let's weigh the side effects. Is the side effect surpassing the possibility and the treatment it gives the person? Now, with chloroquine, it has been used by private practitioners in US and it's still being used all over. What happens is if you use chloroquine at the early phase of the disease, in other words, let's divide the disease into 3 spots: mild, moderate, and severe. So now if you take it at the mild time, at the onset, okay, you start having your symptoms, you use chloroquine, you nip it in the bud, it will work. Okay, fine, it has not been approved, but when chloroquine is used in conjunction with azithromycin, vitamin C, vitamin D, it is able at that level, and you are modulating it. In other words, the person is on chloroquine, you're monitoring certain signs, you're monitoring the kidneys, you're monitoring the heart, provided you are not using chloroquine on somebody who has a G6PD deficiency. This is some metabolism that can cause bleeding. And the person does not have QT malfunctions in the rhythm of the heart. Okay? If those exceptions are not there, and also in some literature you have breastfeeding and pregnancy. If those things are not there, chloroquine can and has been used. Yes, like I said, WHO has not approved it, but it's being used, and in the pharmacology of the chloroquine, it's able to go, when you use it together with zinc, is able to inhibit the replication of that virus. And so if you catch the virus, before it begins to replicate itself and the viral load increases, you decrease it. So what happens is you decrease the viral load, the symptoms the person is having, it decreases. And so the person gets better. Like I said, remember I said you must nip it in the bud. You catch it, you deal with it, you hammer it down, it goes. And that's the thing with chloroquine. But everybody wants to be careful, no problem. But while you're being over careful, lives are being lost. Okay, like I said, those exceptions, G6PD deficiency, okay, then you have QT malfunction in the heart rhythm, and then sometimes you have breastfeeding and pregnant mothers, pregnant women. So if those exceptions are not there and you are using your chloroquine and you are modulating it, it's important you modulate it. In other words, you're using it, you're monitoring signs like your electrolytes and your urea, and yes, it's fine. And of course, you combine with azithromycin and the zinc with your vitamin C, okay, and vitamin D. This thing works. It works. So much protocol, bureaucracy, everything to get approval, lives are being lost. And so let us tailor the treatment to our own environment. We don't have the technical know-how and everything to follow what we're being told by all these agencies. When I say agencies, I'm talking about international organizations, okay? They can give the approval, but pending that time, the other developed countries, the US and the European countries, they have other things they can use. They have so many other resources. They have the technical know-how. They have the smart technology. So they can, if they want to continue waiting for WHO approval, no problem, no offense. They can afford to do it. They have the material resources to be able to do that. But do we have the material resources to do that? We do not. And so let's do what works for us. That is it.
Okay, Dr. Obilade,
you had a second question, please.
Yeah, I was asking whether, it's the right thing for political leaders to be the ones prescribing. And then as a follow-up to what you have just said, you said to use chloroquine, you have to modulate certain things, electrolytes, urea. An ordinary person who is just self-medicating with chloroquine, is that person not really endangering himself or herself? Shouldn't chloroquine be administered only by those who know its functions in a hospital environment?
Pardon me, but I have to question your question. If somebody at home, malaria we know is endemic. When we have malaria at home, we don't wait for a doctor to tell us to use chloroquine. We don't go to the hospital before we start using chloroquine back then. And so all of a sudden, after 20 years now, fast forward today, we're now being taught that before you can use chloroquine, the doctor must give you the go-ahead. Let's look at it that way. So what we can do is to have a massive, sustainable health education. In other words, we have the information we need. We need to get it to the target audience. Who is the target audience? Okay? There are different pockets of people that we can get across. Now, we know in Nigeria, we mistrust the government. So these people that are going to use chloroquine, it has to be communicated to them by the people they trust, okay? They may not trust you and I because of where they see us. But people, they always have people they trust. They meet every day. People they can relate with, people they can relate to. These are the people, okay, that need to sustain the health education to them. Now, we can give them the health education materials, and then they now go in. It's like you have a capillary network. You know when you have your arteries, your veins, and then you have the capillaries coming in together. Now, these capillaries are the little foot soldiers that we're going to have in the engagement of the people. Because you can't convince somebody who has used chloroquine for malaria that all of a sudden, no, you can't. So it is that health education. Health education is the currency of prevention. Take away that currency, and then you don't have the prevention. So give them the health education to prevent an overdose, to prevent a drug abuse, to prevent a misuse. And that's what we need to do. Let us get to the capillary network of the people and engage them in the use of chloroquine. Of course, you know, for Nigeria, it's not an exception. We have fake drugs. So that's another aspect. But we have to be able to give the information correctly through the right channels, and every other noise in those communication channels must be bluffed out.
Dr. Obilade, it sounds like you're encouraging people to self-medicate, which is a bit worrying given that the Presidential Task Force just yesterday told us that the majority of deaths that we are seeing from the novel coronavirus in Nigeria is due to people self-medicating.
I have not seen the statistics. I have not seen the statistics of people self-medicating and dying from chloroquine. You understand? I mean, I have a population of 200 million people. I don't have the statistics to be able to comment on that, oh, this number of people, or this percentage of people died from an overdose of chloroquine. Again, communication, health education, go to the capillary network. If you engage the people at the right level, at the microcosms level, you engage them, you tell them exactly what they need to do. Because if people are waiting, when the case is still mild, and by the time they get attended to, it has now become severe. You see, a virus that replicates rapidly, that doubles exponentially, it's an unseen enemy that is ready to do battle and wants to win. So the way we can win the battle is to nip it in the bud. So when it is still at the mild level, you cut it off. Because by the time it's at the severe level, the virus has replicated.
Okay, Dr. Obilade, let's go on a very quick commercial break.
Still with us is Dr. Titilola Obilade. Dr. Titilola Obilade is an associate professor of public health at the Nile University in Abuja. Dr. Obilade, well, we've been talking about chloroquine, and Leila raised the poser about whether or not you were recommending self-medication. But earlier, you talked about vitamins, and so many Nigerians are buying up vitamins, vitamin C, vitamin D, whatever. People are recommending all kinds of things, including tablets that contain zinc. Now, what is the role of these vitamins in the treatment of COVID-19? Are they prophylactics, or they can cure COVID-19?
Thank you. The vitamins cannot cure the COVID-19. As you rightly said, a prophylactic is something that you take to prevent it. In our body's immune system, we have the white blood cells, okay? Now, it's okay when they function very well, but you and I, nobody really knows what our immune state is, just like that. So what those vitamins are doing is to boost it. And the vitamins in particular that boost it for the fight of the coronavirus in this case is the vitamin C, the vitamin D, and then we have the zinc. You see, in the replication process of the virus goes into the cells and it commands the cells of the host cells to begin to replicate it just like every other virus. And there's several steps involved in it. So what happens for vitamin C? It looks at those cells, okay? During the process of the replication, a lot of oxygen comes out, and that oxygen damages the host cells. That's why we call the vitamin C an antioxidant, okay? So what it does, it mops up the excess oxygen so that the host cells will not be damaged. In addition, Okay, it inhibits that replication. Now, vitamin D, if we are under the sun, just like we are in Africa, okay, we get exposed to the vitamin D from the sun. But most of us, because of the lockdown, we have not been that much exposed to the vitamin D. So it is good to get that vitamin D supplement, okay? Because also it buffers the immune system. And then the zinc in the replication of the virus, the steps, maybe the virus should take 3 steps before replication. What the zinc will do, it will take away step 2, for example. So step 3 cannot take place. And so the viral load is lessened. So those 3 things will operate in boosting the immunity. So if one should now have the virus, what happens is the immune system, the white blood cells, they can now defend. The white blood cells are the soldiers. So since they've already been ramped up, you know, it's like they'll have the ammo. The ammo is like all those vitamin C you've put on all the white blood cells, the lymphocytes that are going to fight it. So what is going to happen is that they are ready for battle. So immediately they sight this enemy antigen, okay? They go right there, attack it, and destroy it. They neutralize it. Now, in addition to the vitamins, if one takes fresh fruits in season, okay, one can get those vitamins, okay? Of course, we have to take our vitamins in moderation. In other words, because they sell some in 1,000 milligrams, some in 100, we have to be careful because overdo is always excessive and can be harmful. Like 100 milligrams would be okay for vitamin C every day, not the 1,000 milligrams, because we know it's water soluble, and even though it's water soluble, excess will be moved out, but we have to be careful because some people do not have good working kidneys to excrete it. So those things must also be regulated.
Thank you, Doctor. Now, can this virus also mutate? We've had reports of a secondary infection that's been seen in children, about 100 reports so far, an inflammatory lethal, potentially lethal syndrome that has been reported, and about 3 children have died so far. So what is your response to this? Can it mutate?
Yes, that is quite true. It has been reported it can mutate, and when it mutates, what it does, you see, a virus, we can describe it as a non-living thing surrounded by a layer of fat, okay? But it's able to replicate. So what it does, it cannot replicate on its own. So it wants to hijack the host cells and replicate itself. So what happens with the virus is that it wants to change pattern, because as soon as the immune system, the white blood cell has recognized, oh, this is an enemy, boom, let's attack it. What the virus does, just like any enemy, you know, a real life human being, you know, soldiers are fighting, they want to camouflage, you know. So what is happening is that the virus mutates so that it can survive, because it wants to go on and procreate itself. So yes, it can mutate, and that becomes problematic, because if you're still trying to develop one vaccine or the other and all that, and it mutates, although when it does mutate, as long as it's still the same virus mutating in 1 strain, 2 strains, 11 strains, it's still okay. It's still manageable. Because most times it can mutate, but it still generally consists of the same body of the virus.
Well, Dr. Obilade, you are an associate professor of public health. And what we're dealing with COVID-19 is a public health emergency. The federal government has taken a number of steps, including setting up a special task force to deal with this. The Nigerian Center for Disease Control has also been very active. And then at the state levels, you also have task forces. What's your assessment from a public health management perspective of what government is doing or has done so far?
Thank you. First of all, I want to appreciate our fellow doctors who have been on the front line. They've been doing a great job. It's just that there's room for improvement. Now, the figures that come out every day, I have checked, I haven't seen, so maybe it's out there, but I have not seen it. Like the numbers of those that have recovered, the numbers of those that die, it will be good to look at the social demographic. In other words, what is the age, okay? If 200 people have died, let's now be able to put it in a graph form or tabulate it and say, okay, the number of those that have died, 20% of them are from the age group of 40 to 60, and then maybe 40% are from the age group of 60 to 80. You know, those numbers are important. And then for those that recovered, let us also look at the demographics and say, okay, what is their age? Which areas are they coming from? And then we look at what comorbidities do they have? So that we'll look at it, so that way we can identify the weaknesses and the strengths. But looking at the figures just like that, like I said, there's room for improvement. You need to be able to interpret it. And then we need to have an objective, a general objective, specific objectives, and we're able to tweak it every week. We can target that, okay, this week, this is the target we're going to do. We want to target this number of tests because really, Nigeria's population is 200 million, approximately. We're staying landmass of like 900,000, almost 1 million kilometers squared. So a lot of the things that we're copying from the developed world, we're not able to actualize it. It's fine. We have good intentions. And so what we need to do is to tweak it to ourselves. You see, we're looking at numbers. People are giving numbers. America has been giving numbers since like 1968 or so, like call 911 call. So they've had the practice of calling numbers. So every nook and cranny of the US, and they can have phone reception. But here in Nigeria, we have places kilometers apart. They don't have phone reception. And then that's all we're doing. So another thing I would like to see, those who are admitted, those who have suspected, those who are confirmed, what steps did they take from the moment they made their first call to the NCDC number and when they got their attention of maybe making them have a test? What were those steps? How many times did they have to call? What did they do? You see, that way we're able to tweak our response. Okay, did they have to know somebody? Did they have to go through somebody that knew somebody that knew somebody? You know? Or, you know, they just made a call, they didn't know anybody, and within 3 hours, they were at their door. Or is it 3 days? So, you see, so those are the type of things, as a public health physician, I'm interested in knowing, because that way we're able to do a formative evaluation every time. So every week we want to look at those records, okay? What have we done? Where are our strengths? Where are the weaknesses? Who do we need to know? And then we have the fake news. There is power in the fake news, but there's more power in the rumor dispellers. We need to aggressively dispel the rumors. So let's say some news item comes today and it's fake. It comes at 5:15 a.m. By 5:45 a.m., the rumor dispeller should have been able to send out more WhatsApp message than the initial rumor, because the rumor spreads exponentially. So those are things, and so you see, those are things I would like to see improvement upon. And like I said, there's always room for change. And then the communication, like I said in one of the previous questions, we need to get to capillaries. The communication can't just flow down vertically like that. No, it has to be horizontally. Get to the pockets where there is no information and they don't trust the government. Get people that will trust them and will give them that information. And then look at the number. Let there be a plan B. Okay, if you call this number 1, 2, 3, 4, 5, all this, and you don't get it, what do you do? And then for you and I and others, you know, it's like, okay, what is in place? What plan is in place in case I have to call this number and I don't get it? What happens? So let the people know what the alternative plan is. But just to have that number, you see, like I said, it's a very good idea. It's a brilliant idea, but we're not yet up to par to be able to sustain it the way it's brought up to be, like in the developed countries. But yeah.
Thank you very much, Dr. Obilade. That will wrap it up on this segment. Thank you very much indeed for honoring our invitation.